Yeah.
Very good afternoon to India from Bad Krotzen from Germany. I'm very pleased to be a member of this webinar, and thank you to Sreenivas for nice introduction. And so, dear friends, this is a really difficult. There is a lot of background noise. I don't know, Anand, maybe you could manage this. So this is really a very tough time for everybody in the world. And in every cath lab, we have to tackle also COVID patients. And I will just make also a few comments regarding how to manage COVID patients and how was our experience. Can you see now the slides?
Yes, we can.
So as you can see here, we are located very southwest part of Germany, and we are now university heart center. So we have together 15 cath labs and perform around 5,000 PCIs a year. And you see many yellow points. So this is just to see how is cooperation with different centers, smaller hospitals. They send patients to our institution. So this is a very country-like area. You see a huge building, and if you go inside, it looks very nice. So we do a lot of complex PCI. We're really specialized to bifurcation lesions and to CTOs procedures, and we do something around 400 to 500 left mains PCI. So we also start our FFR program. So at the moment we are by between 15 and 20% of use of FFR. I think this is important point, and we have also a CHIP program. So how often do we see left main stenosis if we treat patients with PCI? So you have to take into account something around 5% of our patients have to be treated for left main stenosis, and 80% of left main stenosis are localized in the distal part. And you see the distal left main stenosis is definitely here part of a complex anatomy, and we have to tackle patients who are older, who have a lot of comorbidities, and that's a huge problem, I think. And they have not only bifurcation lesions, they have calcified lesions. The vessels are tortuous, and usually we have multi-vessel disease. So this is, I think, a really big problem. So for that reason, you need to perform perfect lesion preparation. I think this is one of most important topics. You need good wires, you need good balloons, you need imaging, and you need good stents. And one of settings in our center, one stent which we really like to use is Onyx for calcified lesions for left main, due to option to go up to 5.75 millimeters. So this is a really huge opportunity to treat practically every left main without malapposition. So with a very good option to go to the side branch, and especially if you treat the left main, you have to go to the circ. Usually you go from left main to LAD, and you treat circ at least by final kissing. And we know also from the comparison of syntax high-risk registry, so all these patients were not randomized, and there was a comparison for the treatment cabbage versus PCI, and you see here a huge significant benefit for patients with PCI. And this is our daily setting. We have patients with who are non-suitable candidates for cabbage, and then we have to manage such patients in our cath lab. And regarding to ESC guidelines from 2018, the latest edition of ESC guidelines, you see we have here regarding the left main, we still should use syntax score just to have orientation how complex the anatomy is. And if we have isolate left main stenosis with global syntax score below, you can go with PCI, it's 1A indication. Of course, you can go with cabbage, but due to less invasive strategy of PCI, doctors and especially our patients will choose they will choose interventional treatment. If you have syntax score between 23 and 32, there is option to go with PCI, but primary you should at least discuss this case with surgery. And if you have to treat left main stenosis in complex anatomy, global complex anatomy with very, very high syntax score, you have to go to heart team discussion. You need to be on the safest way. And we just analyzed our 1,300 patients with syntax score, with estimated syntax score, and we just we saw patients with high syntax score over 30. They go only in around 10% to cabbage. And the question was why? And the explanation for that point is they are usually much older. They have comorbidities. They have decreased LV function, and they're really not good candidates for surgery. And that's why they usually say, okay, go to perform PCI. This is once again, if you have left main, low syntax score, you can go with PCI. And how to do this, I try to show you in next slides. So one remark to COVID's approach in our center. So we, in around in the second half of March, we stopped to treat patients who were elective patients. So we had to treat only emergency cases. And if you have cath labs in India and Bangladesh, so it's really very important to, if you have few cath labs in your institution, just decide to have one or two cath labs which will be responsible to COVID patients and other cath labs, so you can work with standard patients. And what is really very important to have under pressure in the cath lab room. I hope you understand this point, because this is protective for doctors and nurses. So you reduce very much the infection rate. So you have to restore under pressure in the cath lab room. Full protection for medical persons was and is still good available in Germany. However, to begin pandemia, we were a bit skeptic. But now we have only in Bad Kreuznach, we have 46 ventilators. At the university, we have 150 ventilators. And finally, we expected, I'm sure we saw the picture from Italy, and we were prepared for this wave of COVID patients, but this wave didn't come. So thanks God, okay, but we were prepared. And what we observed, and maybe you also observed this point in India, we observed, if you compare April 2020 with April 2019, we have a reduction of patients with acute coronary syndrome of around 15 to 20%. And what is the explanation for that? Many patients are staying at home and just tolerate chest pain, and they came too late to the hospital. They came if they are already in cardiogenic shock, whatever, and this is difficult for us to manage. So for last 2-3 weeks, we start to treat our elective patients as a standard, as is earlier. So, and we have a lot to do. There is a huge number of patients now waiting to get PCI. And you see, this is I think, good introduction to left main. This is a older lady with subtotal distal left main stenosis, very calcified. It's maybe not good to see here. And you see the problem is Medina 111 bifurcation. There is some LAD problem, and this lady has ejection fraction of around 20%. So we performed this procedure here with under impeller protection. This was August 2019. And you see, we didn't perform rotablator, and I think it was from today's point of view maybe a mistake, because we still had a lot of plaque material. So there was not, from my point of view now, not really perfect reduction of plaque material. And if you just take a look what happened now in April in COVID area, this lady came with acute coronary syndrome, very unstable, and we saw this problem. So you see, especially a really subtotal occlusion of circ, and this is exactly the problem in the distal left main. Usually we can treat the line left main into LAD very nicely, but the problem is circ, and the circ osteotomy is still not resolved issue in left main bifurcation. And you see, we could rescue this lady with our equipment, COVID equipment, etc., etc. What we have done, we put it wires into in 7th French. On both wires, we had balloons prepared. They were here, wires and balloons were here. And then we started to wire LAD and to wire circ. It was a bit more difficult. However, after wiring, we could go very gently here and fast, very quick to the ostia of LAD and circ, make first kissing to restore the flow between some short resuscitation, heart massage, chest pain massage, and compression, chest pain compression. And then finally, we put stent in stent here, onyx from left main to LAD, and we treat osteoma, the circ, only with a drug-eluting balloon. So this lady could survive COVID and even this dramatic situation in the cath lab. So according to the approach for this left main, there is still clear recommendation from European Bifurcation Club, if needed and if possible, try to go with one stent and to perform final kissing. And this is usually needed to perform because in the distal left main bifurcation, this relevant side branch is practically important in 100% of cases. In non-left main bifurcation lesions, only 1 of 5 side branches are really hemodynamically relevant. I think also important message. So how to do this? So you stent the left main usually from left main to LAD and do final kissing. There are optional technical approaches. You can use tap, you can use culotte, you can use double kissing crush, for which we have the best options. And again, all technical modalities have some beneficial steps. Tap is very simple. To place stent in the side branch is sometimes difficult because you can have a gap or you have two large protrusions, stent protrusion into the main branch stent. So this is sometimes not really optimum. But if you have here large angle, I think this is one of good options to manage left main with two stents. Culotte is other good option. You should know it's a bit more technically challenging compared to TAP, and at the moment very popular in Asia and especially in China, and a very good data regarding to the randomized trials from Dr. Chen. Dickey Crush is always now, at least in Asia, proposed to be a first choice. I have to say honestly, in Europe, we are still a bit skeptic. There are some centers, they even don't use Dickey Crush even for left main. So we use it and we take a look to anatomy. And if we have a very large angle, so there is option to perform tap. Culotte is here not really good option. Dickey Crush also not perfect. If we have this anatomy, a very huge side branch and small angle here, I think this is ideal to perform culotte stenting, which is technically less challenging than a Dickey Crush. And we have in some options here, not really good option to perform culotte because of the difference in diameter between side branch and main branch. If this difference is larger than 1 millimeter, so let's say here approximately have 4 millimeters and the side branch 2.5, it is really not good option to go with culotte. And if you have a small angle here, it's really not good option for tap, because then you have here large protrusion. So that way, this will be perfect case to perform Dickey Crush. And what we do now is BBK retrial comparing culotte and Dickey Crush in non-left main bifurcation lesions. So there are some randomized studies, head-to-head comparison. We have Nordic 2 study, Crush, Classic Crush, and culotte. No significant difference. I ran.
I'm sorry.
All right.
Have you joined through your phone also? Since there is a bit of echo coming from your end, so just wanted to recheck that. Have you joined through phone also? So it would be good if you can keep the phone at some distance so that we don't see any echo.
Okay, you mean it's maybe better now?
Yeah, this is better now. This is better.
Okay, so if you go forward and compare then BBK2 trial, culotte and TAP, there was a beneficial result for culotte. We had here around 50 left main cases in this study. So it's really a difference for the side branch. And you see there is a very clear trend even to lower target lesion failure for culotte as compared to TAP stenting. So as I told to you before, there is plaque shifting. Usually plaques are coming from left main to LAD in 90% of cases, and then also left main plaque going to circ is around 2/3, and mixture of both in 62%. So you should know, especially younger doctors, that the diameter that is the left main stenosis is something between 4.0 and 5.75 millimeters. So you need, and this is, I think, very important point, you need a stent which can go up to nearly 6 millimeters. Then you can treat practically every left main stenosis. Excellent option to use here on stents with this huge option to postulate adequate and to avoid malposition. So ABC main study is now in analysis. So it's a comparison single versus double. And we know from Dickey Crush study that comparison culotte versus Dickey Crush was by angiographic endpoint better, and Dickey Crush was also better in comparison to provisional T-stenting. So this is here just to show you the different steps in Dickey Crush. I think all cath labs, if they can go this way, they can use this approach. People who have more experience with TAP or culotte, they should use it culotte and TAP. There was some learning curve to get experience in Dickey Crush. So how often do we need predilatation? In majority of cases, we don't need to predilatate the side branch. And there are only few situations when we need to predilate the side branch, even circ. You can have subtotal, if you have subtotal stenosis of the side branch, if there's calcification in the side branch and the lesion is longer than 15 millimeters, then you have to perform predilatation. So dear colleagues, I just skip here. I wanted just to show you this option here. Sometimes you have a very difficult anatomy and you are not able to manage this with standard wires. For that, you need special wires or special techniques like you can use it, you whisper wire to make such decision. This is now for diagonal branch, but sometimes you have very similar option for left main. You can go right, and finally you can go with here culotte stenting. You can manage even such difficult anatomies. So it's important to have a good stance even with optimal side branch access like Resolute. Okay, thank you so much. Much, and I'm open.
Hello.
No, because time is running, so I stopped my presentation here, and we should go forward for other presentation and then for discussion. I think it's more important.
Sure. Dr. Sreenivas, over to you.
Yeah, I think we can have more of it from your discussion in the discussion time, sir. Now we'll go on to Professor Fazila Malik's lecture. Let us hear her experience in Bangladesh about the left main stenting, what you have to learn from her experiences. And Dr. Fazila Malik, welcome again. Over to you. Can you hear us?
Yes, I can. And can you hear me?
Yeah, I can hear you, but you are yet to get your slides, man.
Okay.
Yeah. I think we're able to see you and see your slides too.
Great. So thank you so much for inviting me, and it's lovely to see you as well and all my friends. So we've been so occupied with COVID all these months. So this makes a good sort of change for all of us to talk about something new and something different rather. So I'm talking about left main. And many of you might be aware that I work at the National Heart Foundation Hospital and Research Institute, which is a 480-bedded tertiary cardiac care hospital in Dhaka, Bangladesh. And we started with a single cath lab in 1999. At present, we have 5 fully functioning cath labs. We've done more than 40,000 PCIs over the years. We started doing left main PCI on a regular basis in 2007. In October 2019, we've done more than 2,000 left main PCI. Of these, 78% of our patients had distal left main. And in these distal left main patients, for the vast majority, 80% of our patients, we treated them with single stent strategy. Only in 19%, that is around 300, more than 300, we did double stent strategy. Regarding our double stent strategy, our strategy has sort of changed and evolved over the years. Initially, we were doing a lot of TAP. After that, we did quite a bit of culottes. And this year, since 2019, we started doing DK crush. Regarding the general, in around 93% of our patients, we used a second or a third generation stent, and in 50% of the cases, it was a Dr.A.Sreenivas eluting stent, and in 28% patients, it was a Dr.A.Sreenivas eluting stent. We've managed to follow up the vast majority of our patients, and we did symptom-driven check angiogram for around 164 of our patients, and we found that in 144, that is 88% of patients, the stent was patent for these patients. Our overall MACE is 9%. Now, just on a slightly different note, as I was saying, in around 51% of our patients with left main PCI in our center, we used a Dr.Mirslow eluting stent. And as many of you are aware that in this part of the world, especially in Bangladesh, we have a very high prevalence of diabetes mellitus. So we thought that it would be interesting to see how these patients fare. So with that in mind, we had an independent statistical body do a study for us, and we found that in 884 patients with left main PCI who had Dr.Mirslow eluting stent, of these, 458 were diabetic, the rest were non-diabetic, and we followed up these patients for a 6-year period time, and we found that the all-cause mortality for these patients was identical, both at 1 year and at 6 years. And obviously, this was a great news for us, especially for our diabetic population who usually have very complex disease. Going back to the main thing, that what is our experience and what we have learned. But one thing that we have learned, I feel, is that you should keep a left main procedure as simple as possible. For instance, in this distal left main PCI, trifurcation lesion with the LAD was a CTO, we first opened the LAD, and once we had opened the LAD, we did pre-dilatation, and after that, we took a stent from the shelf that we knew would not compromise our side branch and would give us great side branch accessibility. We deployed that stent. So we used a single stent technique here. We did proximal optimization. And as you can see, the immediate result was great, and the long-term result was also pretty well. So keeping it simple is, I think, something that we learned from our experience. But another thing is that sometimes the lesions can be so complex that you have to know from the very beginning that you'll be doing a double stent strategy. Like This patient, we knew from the very beginning with this Medina 111, we would definitely need a double stent strategy here. So strategizing and knowing what you want to do is very, very important when one does a left main. And I would think that usually we never ever do left main PCI double stent strategy on an ad hoc basis. We usually have our strategy at hand. Only if it's a emergency, then you would do a double stent strategy on an ad hoc basis. So here we did a tap technique, whatever the technique, while the procedure is being finished in a double stent technique, a final kissing is absolutely mandatory in double stent technique. And IVUS obviously helps when you are doing complex cases, you're using two stents. IVUS helps in optimizing the results, giving you an idea about the size and other things. Talking of size, speaking of size, we all understand that the vast majority of left patients have a vessel size of more than 4 millimeters. So it makes sense to use a properly sized stent. Like in this patient, we did a pre-procedure IVUS and we found that the size of the left main was 5 millimeters. So for this patient, we took a 5x26 drug-eluting stent and we deployed it from left main to LAD. We did a tap technique here as well. And after final kissing and proximal optimization, we did IVUS, and we saw in the IVUS that the stent was both properly sized as well as properly apposed. And if you use an undersized stent, this can lead to unforeseen consequences and poor outcome. For instance, in the 68-year-old gentleman who had multiple comorbidities like CKD, hypertension, and diabetic, and he had a CABG done 13 years back. So he was suffering from angina, and he had an angiogram done 5 months ago in another center, where they found that his Lima to LAD graft was patent. However, his SVG to OM and PDA were occluded. So in that center, what they did is they put a stent, a 2.75 by 30 millimeter drug-eluting stent from left main to LCX. Now, 5 months down the road, he started having chest pain. This time he was admitted in our hospital and we did an angiogram and we found that there was a 95 to 99% ISR involving the LAD to LCX. We wired that vessel and we attempted to take her IVUS because we wanted to ascertain whether this stent was undersized, because that was a very strong suspicion we had, but we were unable to pass our IVUS. So what we did is we did pre-dilatation with a 2.5 by 12 NC balloon. After pre-dilatation, we were able to take our IVUS and we saw indeed the stent was grossly undersized as well as malapposed. So what did we do? We did pre-dilatation again, now with a 3.5 by 8 millimeter NC balloon. This time we went up to very high pressures. Only after that, we attempted to take our stent and we took the most deliverable stent that we had on our shelf, because obviously it would be a bit of a challenge to take a stent to that previously deployed. Stent went very easily. We deployed it. We did proximal optimization, post-dilatation, and this was the final result. And this was the IVUS shot of that vessel. So undersizing should never ever be done in a distal left main disease. That's what we learned. And sometimes these patients whom we tackle with distal left main disease, they sometimes has very protracted long-time problems. And in these patients with complex history, obviously the stent that we use has to be of the optimum design. It obviously has to have great radial stent. It should have great radio opacity, easy deliverability, easy side branch accessibility, and great radial strength. And all of these features of a stent came into play for this 55-year-old gentleman who had a primary PCI done in 2016. After that, he had CABG done in 2018. After that, a few months later, he again had chest pain, and the check angiogram showed that there was all his grafts had occluded. So what they did is, in that center in Kuwait, they did a PCI from left main to LAD, and they put another stent from LCX to OM. However, unfortunately, this gentleman, when he came back to Bangladesh, he was again having progressively worsening angina, and he had to be admitted in our hospital. So this is how his angiogram looks. It looks pretty bad. So there is a 90 to 95% stenosis in the proximal part of the LV, of the left main. There is 95% ISR in the ostia of the LCX, and around 40 to 50% ISR in the origin of the LAD. Now, for such a complex case where there's already been CABG, then PCI, and now this, we have to be very, very vigilant and use the best possible tools and do the best possible for this patient. So what we did, we used a Xion blue floppy wire. With the help of a caravel, we wired the LCX. After wiring the LCX, we also wired the LAD with the help of a Xion blue and a caravel. Following this, we started dilatation of the LCX, first with a 2x15 and then with a 2.75x12 NC balloons. We did pre-dilatation of the LAD as well. Following pre-dilatation, this is how the vessel looked. And we decided that for this patient, to give him the best optimum coverage and hopefully the best long-term result, we would do a DK crush here. And one thing about DK crush is that you just follow the steps one after the another. So here also we took the most deliverable new generation stent that we had on our shelf. It was a 2.75 by 30 millimeter drug-eluting stent, and we placed an NC balloon in the left main to LAD. We deployed our stent. After stent deployment, we removed the LCX wire and we crushed the stent with the 3.5 by 12 NC balloon that we had previously placed from the left main to LAD. Once we had crushed our stent, we again rewired the LCX through the stent strut, and it went very easily. We then did our first kissing with a 3.5 by 12 test in the left main to LAD and a 2.75 by 12 millimeter NC balloon from left main to LCX. After our final kiss, we did proximal. We then removed the wire from the LCX and we placed a 3.5 by 30 desk from left main to LAD. And for positioning of this stent, obviously the radio opacity of our stent helped. And we also took the help of a cuspal wire to properly position our stent in the ostia of the left main. We deployed our stent. After stent deployment, we did proximal optimization with a 4 by 12 NC balloon. We again rewired the LCX with the help of a caravel. And after this, we did a final kiss with two balloons, one in the from left main to LAD and one from the left main to LCX. We did report with a 4 by 12 NC balloon. And this was the final result. And we also did OCT as this was a live case that we are doing. I'm sorry, I don't have the moving pictures, but we also did IVAS as one of the panelists asked, and we could see that the ostia of both the left main and the LAD were properly covered and were well open, and the left main looked just fine. And this patient has been doing very well, which shows the DK crush in the long run, in many cases, does work. Now, that was one patient where the stent design came into play. One thing that I've also noticed, we have noticed, is that in patients with complex distal left main disease, often these patients have such a lot of comorbidities that they have already been refused by surgeons. And such was the history of this very elderly 82-year-old frail little lady who had severe calcified vessels. See, she had multiple comorbidities, and she was transferred from another center where her angiogram was done to our hospital for PCI. She had severe triple vessel disease involving RCA as well as the left main. So for this frail lady with poor renal function, we decided to stage the procedure. So we first tackled the right side. We did the PCI on the right side. And a few days later, we decided to tackle the left side. And as you can appreciate just from the fluoroscopic view, that the left side has a huge calcium burden. Now, for this lady who's frail, who's 82, who has poor kidney function, creatinine of 3.2, she would not tolerate a prolonged procedure. And so we knew that for her heavily calcified vessels, we would need to do rota early on to get an optimal result. So first of all, we did rota ablation from left main to LCX. After rota ablation from left main to LCX, we went on to wire the LAD, and then we did rota from the left main to LAD. After that, we had a look with an IVUS, and we found that there was still a lot of calcium load left. So we stepped up our burr from 1.25 to 1.5, and we did rota ablation again. The final rota ablation, this is how the vessel looked, rota ablation of both the LCX and the LAD. For this lady as well, we felt that for the best long-term result, we would do a DK crush. As I was saying also, for the DK crush, they're just one step follows the other. So it's like, following a recipe, you don't really have to take shots to see how things are going. You just follow the steps, and the minimum amount of dye is required. So here, especially in CKD patients, we feel as a team that DK crush really works. So what we did is we wired both vessels, and we took a 2.5 by 28 test from left main to LCX, and we placed a 3 by 15 NC balloon from left main to LAD. We deployed our stent, we removed the wire and balloon from the LCX, and then we crushed the LCX stent with the LAD balloon. After that, we rewired the LCX with the help of a fine cross. After wiring, we did our first kissing with 2 NC balloons, one from left main to LAD, the other from left main to LCX. After the first kiss, we placed a 3 by 33 drug-eluting stent from left main to LAD, and here also we used the cuspal wire to guide the position of the placement of the ostia of the left main. After deploying our stent, we did proximal optimization with a 3.5 by 8 millimeter NC balloon, and we went to very high pressures. We then rewired with the help of across the LCX. We then did our final kissing with 2 balloons. And this was the final result after report. This lady who could barely walk is now active, and she's really doing well. So this is another case, complex. Usually distal left main, for a variety of reasons, can be very complex, and you really need to have the tools available, the stent available to do a good job. And obviously, you need to strategize. So in conclusion, from our experience, what we would like to say is that for optimizing outcomes of left main bifurcation lesions, you need to decide on a proper strategy early on and try to keep the strategy as simple as possible. When a double stent strategy is required, the operator should obviously choose a technique that he is comfortable with and familiar with. Proper lesion preparation is absolutely mandatory for good long-term results. And in heavily calcified lesions, for lesion preparation, rota should, we feel, be used early on. Imaging modalities like IVUS and OCT help optimize the outcomes. And the desk chosen should obviously be very important, be of proper size, excellent radial stent, have good radio opacity, easy side branch accessibility, easy deliverability. And after stent deployment, we need to do final kissing, port, and report. And I think very important is that you need the proper tools in the cath lab, and you need a team of people who are used to doing left main PCI. So the team is also very important. From the entire team, this photo was taken in the pre-COVID era. So from the entire team of National Heart Foundation, thank you.
Thank you, Professor Fazila. Can you unmute my mic? Uh, Thank you, Professor Fazila Malik, madam. And thanks for sharing your experience from your center. Good to see all your team too. And thanks for highlighting the fact that even in diabetic patients in Bangladesh too are doing well with PCI. And your point of keeping the procedure simple and using a double strength strategy if required, and heart team approach is what is most important, and keep and to do good outcomes to patients. And you also shown some important imaging methods in between to see, especially in instant response and other types, how this can help. I think we'll have more discussion after the other two talks. We're running slightly behind the schedule, so I request next speakers also to keep this in mind. And now we go on to the third talk of our webinar. Dr. Rajesh Vijayvergia, professor of cardiology from PGI. He'll be sharing with us his experience of treating one of the chip case of left main with image guidance. As you know, Dr. Rajesh is seriously publishing newsletters with imaging and a lot of interest in OCT and IVUS imaging. Let us learn to hear from him from what is his experience about managing his chip case. Over to you, Dr. Rajesh. Can you change the slide sharing? Yeah. I think we are still fascinated with madam. Okay. I think now I can see, we can see his slides.
Dr. Sreenivas, good afternoon. Can you hear me and can see you?
Yeah,
can
yeah.
see me?
Perfect, sir.
Okay,
We can
great.
hear you. Slides also there. Go ahead.
Okay. So good afternoon, everyone, and thanks, Medtronic, for this bifurcation left main webinar. Let me go ahead with my case. This is a case about a 64-year-old hypertensive non-diabetic male who presented with angina on exertion class 3 from last 2 months and rest angina later on in January 2020. Clinical examination was unremarkable. ECG did show the ST depression in the first AVL, V2 to V6 and inferior leads. Echocardiogram did show ejection fraction, which was normal. And this is the angiogram, which showed the mid-RCA tight stenosis, and then there is a left main distal tight block. This is the epicranial. The mid-LAD is also having a 90% stenosis. Spider view, it's a bifurcation left main disease. So basically, the diagnosis is the left main bifurcation plus triple vessel disease, EF 60%, non-diabetic with good vessel size, and then revascularization has to be done, whether CABG or PCI. We opted to go for the PCI in this case. And then a 3 into 15 millimeter balloon dilatation of mid-RCA was done, followed by the IVUS, which showed a reference vessel diameter of 4.94 distally and proximally 5.24. And then we did put a 5 into 26 millimeter resolute onyx in the mid-RCA, and TIMI3 flow was achieved. 3 days later, he was taken for the PCI to left main. Considering the complexity of the case, we did put the temporary pacemaker and also the IABP support from the left side and from the right femoral. Went ahead with the PCI of the left main. EBU7F guide was used, and if you see, there is a TIMI1 flow across the LCIs, which got deteriorated in last 3 days after doing the PCI to the RCA. This is the epicranial. You can very well see 111 left main bifurcation disease, and the mid to distal LAD is also significantly disease. Following the dilatation with 2.5 millimeter balloon of the left main, IVUS was done, and this is the IVUS run across the left main to proximal LAD, and the reference vessel diameter of the left main was 5.6. Ostial LAD 4.4, proximal LAD 4, and mid LAD, where again the tight stenosis was there, is 3 millimeter. So here the PTCA balloon dilatation of the ostial LCS was also done with 2.5 15 millimeter balloon, and this is after the balloon dilatation of the both left main and the proximal LCX. Distal LAD was also dilated with 2.5 millimeter balloon. And a 3 into 38 millimeter resolute stent was deployed in the mid LAD with the good flow across the stented segment. And here is the left main bifurcation lesion. So now, of course, there is a two stent technique has to be used to go ahead for left main PCI. So which technique, mini crush, culotte, tap, or DK crush? It depends on the operator experience and favorite technique depending on the individual operator. So we dilated the left main with a 4 millimeter NC balloon, and thereafter this is the check angiogram. You can see there is some dissection in the proximal LAD, good flow across the left circumflex. And this is the IVS across the LCX to have an idea about what the reference vessel diameter of the LCX, which was 3.34 at the ostium, and proximally it's a 3 millimeter left circumflex. It's a fairly a big size left circumflex, which angiographically was not looking so great. And here comes the problem. Patient had an acute closure of the LAD, augmented blood pressure on IABP support dropped down from 130 to 80 millimeter mercury. Hurriedly, a 4.5 30 millimeter resolute stent was deployed from left main to LAD, covering the mid part of the LAD, which was already been stented. And this is the flow across the left main to LAD. Flow was achieved after stenting. And then it was a post dilatation was done across the left main to LAD with 3.5 in the mid part of the LAD, 512 at the ostium of the LAD, and 6 millimeter balloon dilatation at the left main. Again, there was a problem, slow flow across the LAD. Again, there was a fall in blood pressure to 70 millimeter on IABP itself. So what next? Which drug to be given? Adenosine, nitroprusside, nitroglycerin, nicardipine, or adrenaline? Here the condition was rapidly deteriorating, and therefore I did give an intracoronary adrenaline, following which there was an improvement in the flow across the left main to LAD. It is followed by a dilatation of the left circumflex with 2.5 15 millimeter balloon, and a 3 into 15 onyx was deployed across the ostial circumflex as a tap technique. Final kissing was done using 3 into 12 across the LCX and 4 into 12 balloon across the left main to LAD. And this is the TIMI3 flow across the left coronary system, good flow across both LAD and left circumflex. Final IVAS was done across the LCX, and LAD mean luminal diameter of the LCX was 3 millimeter. Mean luminal diameter of the left main was 5.58. Ostial LAD 4.2, 3.98 is the proximal, and of course mid to distal LAD it was 3 millimeter size of the vessel, which was achieved following stenting. This is the IVAS run across left main to LCX. And this is across the left main to LAD, well opposite stand across both the vessel. So IABP was removed after 4 hours of the intervention. Bilateral femoral artery hemostasis was achieved by ProGlide. A CKMB was done after the 6 hour, which has a rise from 8 to 80 international unit per liter. And at 5 months of follow-up, the patient is doing well. So the take-home message of the particular case is that left main bifurcation PCI using tap tactic with IVAS optimization was done in the index case. There was the LAD dissection initially and later on the slow flow, which was appropriately managed. And IABP and TPI support was useful in this particular case to see come out or to bail out safely and have a good result. Thanks for the kind attention.
Thank you, Professor Rajesh, for showing an excellent case. I think initially we were thinking whether we were only in corporate styles we were doing such sort of cases, But seeing such cases being done even in the teaching institutes, we get confidence that what everyone is doing right. And many of the questions could be there on such sort of complex case scenarios. I think we'll go on to the questions after we finish. Professor Gambhir sir's talk by SR is waiting. I think, as I already told, Dr. D.S. Gambhir sir is a senior interventional cardiologist pioneering work in left main, and he has done a lot of work in calcified vessels too. I think he has a combination of it now to show the calcified left main bifurcations, how to deal with that. And we request Professor Gambhir sir to share his presentation in this webinar, and we'll have some hope we'll have some time for discussion in the end again. Over to you, Dr. Gambhir sir.
Sure.
We can see the slides, sir.
Yeah, thank you, Srinivas. And good afternoon to all the participants, the other faculty members. In fact, when I was assigned this talk only about 3 days ago, and you would share with me, Dr. Sreenivas, that yesterday I had a full session on left main where I had shown 12 complex left main bifurcation stenting.
Yes.
But I kept a couple of cases for the calcific left main bifurcation stenosis. Well, as you know that calcium is one of the biggest enemies of interventional cardiologists, and there are now several studies which show that the calcium which you detect on fluoroscopy and on angiography, the percentage is much lower as compared to when you do an intravascular ultrasound in the same patients. 38% diagnosis of calcium by angiography versus 73% by was in the same patients. And as I did say that calcium is sensitivity of detecting calcium increases with any of these imaging modalities.
Sir, is your camera off, sir? We are not able to see you. We are seeing you, hearing your voice and slides. Can you make your camera on? Is it possible?
Just wait. Yeah, camera was kept on. Can you see me now?
Yes, sir. Now we can see you, sir. Please go ahead.
Yeah. Now, the absence of intravascular calcium imaging will certainly lead to several problems during PCI in calcified vessels. And as we understand it fully by now, that the calcium leads to a stent under expansion, it leads to malapposition stent, the longer procedure time, and thereby all increase the risk of various complications, including lead stent thrombosis. Well, the Japanese have given a very interesting risk stratification of calcification, how it leads to underexpansion and can lead to serious complications on follow. This is called the OCT based calcium volume index score, where points are given for these 4 variables, which include the maximum calcium angle, calcium thickness, length of the calcium. And 1 or 2 points, as I will not go into the details, are given for each of these various variables. And if the total score is big, as more than 4, then obviously you have a high tendency to have serious problems during the deployment of the stent. So if the score is high, then you need to use some sort of a debulking device, such as either cutting balloon, root ablation, and now even IVA. And generally, it is said that if the calcium is having a depth of more than 0.5 mm, the arc is more than 80 degree, and the length is more than 5 millimeter, then you would need some sort of a drilling device. Well, I have several issues with this classification, and I'll put the limitations of this scoring system. The first is that the calcium length of more than 5 has been given a score of 1. But what about diffuse disease, calcified coronary artery disease? Anything above 5 is called 1, but well, it may be 20 millimeter long It may be 30 mm to normal. It may be diffusely disease right up to the end of the LED or circumflex. So no score has been further added to it. Calcium angle of more than 180 degrees is given a score of 2. But what about full calcium jacket of 360-degree angle? Again, there is nothing said about it. There is no reference or score for the depth of the calcification. Depth plays a very important role. Now, based upon the depth of the calcium, one has to identify the appropriate technique for decalcification. Now, what is superficial calcium? The superficial calcium is when it extends from the intima. What is this? This one. If the calcium extends from the intima but does not go beyond the media, then it is of course a superficial calcium, and in most of these cases, rotablation is the debulking technique of choice. A deep calcium is one which does not protrude into the lumen. It is starting from much away from the lumen and much away from the even intima, but extends beyond the media, maybe even into the adventitia. So that's a deep calcification, and the possibilities of treatment lie between using a scoring balloon or a cutting balloon. And the third is a calcified nodule, where the calcium protrudes into the lumen, and there is a in such cases you may do either a IVL or you may do a root ablation. Slide is not moving. Similarly, the approach which is based upon the length, if it's a focal lesion, then of course the cutting balloon or IVL are preferred, or a high pressure balloon may also be done in some cases. But if it's a long diffuse disease, then obviously none of these cutting balloons or IVL is going to work, and you have to use either excimer laser or a rotational atherectomy. Now, this is my personal experience of the last 15 odd years for the treatment of left main coronary artery stenosis. We have done by now 570 patients. This, of course, does not include the cases done in this year. And now this is a single man's experience. And the bifurcation lesions constituted almost about 2/3 of these, ostial or shaft about 1/3. Emergency procedure of left main stenting was done in almost 5% of these patients. Vast majority, nearly 2/3 or a little more than 2/3, underwent a 2-stent strategy. 13 patients underwent a 3-stent strategy or trifurcation stenting at the left main, and a single stent was used in only about 27% of patients. Amongst the various adjunct devices, rotablation has been used in 31 of these cases, which accounts for nearly about 5.5% of cases, other like IMEP, cutting bone, etc. And the angiographic success has been very good, 98%, and then we have a very few complication rates. Now, the task that I have been assigned is to tell you about the treatment of highly calcific left main bifurcation stenosis using 2-stent technique. The first case which I'm going to show you is very rare case of a calcific left main bifurcation stenosis in a patient with acute coronary syndrome with idiopathic thrombocytopenic purpura. Now, ITP, as we understand, and many of the cardiologists also have some idea from their MD levels, that it's a bleeding disorder characterized by premature destruction of platelets mediated by autoantibodies. The prevalence is very rare, 100 cases in 1 million population per year. And there is the bleeding which may be spontaneous, microcutaneous bleeding, major bleeding leading to even death in 5% of the cases. ITP along with acute coronary syndrome is still very rare, and the problem is the safety of antiplatelet agents in patients who are being treated for acute coronary syndrome or are undergoing a PCI. Well, we do not know as yet, there is no data. There are no guidelines or randomized studies to recommend the dosage, the type of antiplatelet regimes in patients of ACS or who are undergoing PCI with idiopathic thrombocytopenic purpura. So the case that I'm going to describe is 63 years old gentleman. He is hypertensive. He underwent PCI with stent of LED in 2002, that means 18 years ago. In 2009, he developed some sort of angina, and he had an angiogram done in another hospital where LMC was found to be 70%, LAD about 60 to 70%, and LCX about diffuse disease. I don't have the angiogram. This was a report which I was given to understand. So this patient had seen several surgeons at that time, and none of them was willing to do surgery because of two reasons. One, he had ITP, and secondly, they thought that his lesions are not very significant. So this time, that is in 2019, when this case was done, he presented to us with angina on exertion class 3 with occasional episodes of rest angina. His ejection fraction was normal. His stress echo was positive for ischemia, and platelet counts range in different readings from 55 to 61,000 per cubic millimeter. Now, this is ECG during one of the episodes of chest pain, and you can see here marked ST segment depression in almost all the leads with elevation of ST in AVR. Our problem was how to treat this patient because he had a low platelet count, and surgeons were not willing to do his bypass graft surgery. We consulted our hematologist. He said the average platelet counts which has been done over the past 4-5 days that he was with us was about 64,000. So he advised that unless the platelet count crosses 1 lakh, you should not be doing anything on this patient. So he put the patient on a single donor platelet transfusion 3 units, anti-D injections, and then injection soluble withdrawal. And following this regime for 3 days, the platelet count on the morning of his PCI, he was designed for PCI and was to be done live in one of the conferences. His count was 95,000. So we were pretty reassured that we should be able to pull him through the PCI. Unfortunately, on the day of his PCI, at 6 o'clock in the morning, I got a call that patient is having severe angina, and this was the ECG. Again, he had once again marked ST segment depression with ST elevation in AVR. So my worry was that he might be occluding. Since I had known his anatomy, so worry was that he might be occluding. So we gave him a lot of beta blockers intravenously 2-3 times. Fortunately, his pain started settling down, and we had to start the procedure well before the scheduled time of our transmission. So we put this patient, took him to the cath lab. I hope these run. Yeah. So this was his angiogram, of course, and we first put him on IABP. The patient's coronary angiogram, you can see it very well. Is it visible, and is the the sinus moving all right, Dr. Sreenivas?
No, we are now. I think we are just there's some lag, sir, between your talk and this. Now we got the angio pictures, but we are not able to see it moving.
Not moving.
Just click on it, sir. Once we'll see.
Is
it moving from your end?
Yeah, it's moving at my angle.
Maybe it'll take some time for it to come because there's a slight lag in the net.
Because if they are not moving, then you will not get the real view of what is the problem.
Now it's moving, sir. You can go ahead.
Okay, so that's going to take a lot of time. You can see that there is a very critical left main, which is calcified. There is a stent in the LED, and there is a calcification which is extending into the instant restenosis. Very diffusely diseased circumflex with multiple areas of stenosis. His right coronary artery was reasonably all right, but not very big. Now gone on to second slide, where we had wired the both the branches, and before we could do any imaging technique, patient again had chest pain, and since IVUS catheter was also not going, so we thought let's first dilate and make a room for the IVUS catheter to go in. So we wired both the branches and then did a serial balloon dilatations. Is it moving over there now?
Yes, yes.
Okay. So having wired this is the post-balloon result. So by this time, the patient was also given some beta blockers again intravenously. Patient was on IABP. So his pain started settling down, the ECG started settling down. And then we did, I was pulled back both from the LED and circumflex. And these are the IOS pictures. You see that on the extreme left, there is an instant resources in LED with a very fibrotic calcified areas, and the lumen diameter at this point is almost 7.9 millimeter square. As we go towards the ostium, it's a very tight stenosis with 2.45 as the minimum lumen area. And in the distal left main, it is still very fibrotic and to some extent calcified uh, plaque. So we thought that this would be treatable only by doing a root ablation. So we changed the strategy, which of course we had thought that we would require a root ablation in this case. So we wired the LED first and then wired the circumflex. First we did the root ablation in the LED, and the same wire was rotated into the circumflex, and we did a root ablation of the circumflex. Following this, we deployed a stent. Firstly, we thought that we will deploy the stents in the distal parts of the vasculature, and then we will treat the left main. So we first deployed a stent in the distal LCX1. This was a long DES. And then we deployed another DES into the LED, which I'm not going to show here because of the shortage of time. And this was followed by the deployment of a, this is the post-stent LED result, LMC to LED result. And then we took another long stent to cover up the entire LED. We first deployed from the left main to proximal part of the LED. And then through the stent, we covered the mid part of the LED with another long stent. This was 3 into 32 millimeter. And the ostium of the, so this is the LED, which looks fairly okay. Now, we had still to cover the ostium of the circumflex. We did not initially deploy the first stent in the circumflex right up to the ostium because we thought it will be difficult to negotiate if you have to do a tap technique. It will be difficult to negotiate a long stent into this circumflex, which is calcified and having a more than 90-degree angle. So we had left that small area which was to be deployed later on, and this is what we did. Having deployed a stent from left main to LED, we then took a short stent, and using the tap technique, we deployed another stent at the ostium of the circumflex without much difficulty. And then we did a final kissing balloon dilatation, which is mandatory in all these cases, and then did a pot. And this was the post-PCI intravascular ultrasound, which now shows that the distal left main is very big in size, is minimum lumen area of close to almost about 12.2 millimeter. So this is the final result. So we are very pleased to see this result. Everything went on smooth. There was no problems during the procedure, and patient did very well. He has been followed up for almost about 7 months by now. He has been doing reasonably well. Now, I then scanned the literature just to give you a highlight to our participants. 17 studies, 18 patients. The target vessel had been 3 vessel disease in one. None of these had left main treatment when they had ACS with ITP. And the total number of vessels treated were 29. Mean platelet count in this was 78,000. So one can understand that how difficult it was for us to treat a left main bifurcation stenosis with bifurcation stenting in a patient who had such a low platelet count and was having repeated episodes of unstable angina with marked ST segment elevation, depression in various leads. So in conclusion, it was safe and feasible. Risk-benefits equation of PCI and antiplatelet agents had to be carefully evaluated. There are no standard guidelines reported for antiplatelet regime. Dual antiplatelet with clopidogrel and aspirin are effective in preventing stent thrombosis. Strong antiplatelets should be avoided. So I'll take another 2 minutes to show another case which was also shown yesterday, but then I thought it would be good to re-show this because we could not. This is a patient who's got comorbid condition in the form of a carcinoma of the glottis, 66 years male, operated, tracheostomy done. Initially, he came to us with acute pulmonary edema. We treated him medically with decongestive, antiplatelets, and other things. He was stabilized after 3 days. ECG showed inversion in V1 to V6. Echo ejection fraction was 32%. And on the fourth day, we took him up for an angiogram. So this was an angiogram. Distal left main, 80% highly calcified, long diffuse disease, highly calcific stenosis, LCXOMs are all fibrotic, calcific with diffuse disease, and right coronary artery was small but normal. This is the other view of this RA view. So this is the right anterior oblique view, which again amplifies the same findings which have been seen in the epicranial view. Now, the management options was he had a syntax score of 39. Well, ideally, he should have undergone a bypass graft surgery. So we talked to our surgeons, but the surgeons said that since this patient is on chemotherapy, we would not like to do a bypass graft surgery on him. He has a poor early function, etc., etc. So he left it to us. Also, the relatives were not very inclined to do a surgical procedure on this patient who had pregnancy. So the only treatment available to us was a PCI. I will leave these slides. Now, when you have to do a PCI in such a patient, you have to first prepare the bed for the deployment and proper expansion of the stents. Well, these are the list of the various debulking techniques which I put on here. Scoring balloon, certainly no. Cutting balloon, certainly no. Rotational atherectomy, yes. Green mark I put over here. Well, others possibly intravascular lithotripsy, again no. And excimer laser, we have no experience, but possibly could be an alternative. So we decided to treat this patient with rotablation for plaque modification using, and then left main stenting using mini crush technique. So we did a rotablation first using a 1.25 millimeter burr. We didn't do any IVOS technique in this patient. Then we put a 1.5 millimeter burr. And then following this, can you see, Srinivas, can you see the IVOS run?
No, we are not able to. Just I think it will take a while for it to come to a picture.
Okay. So this is a 1.5 millimeter burr. Can you see it now?
Still, we are seeing the plan of your slide. The patient using this technique.
Oh my God.
I think it'll go. The slight lag in your now we are able to. We got the burr.
Yeah. So this is a 1.25 millimeter burr, and then following this, we went with a 1.5 millimeter burr, and then having done that, we deployed long stents. This is a 38 millimeter stent in the ready. I think we can skip some of these. So we can just show you the final result, which is we use a mini crush technique. I hope this is visible to you soon, the mini crush technique, where we have crushed the circumflex stent with the LED stent, long LED stent.
Didn't come there.
And this is the final kissing balloon inflation. I'll just show you the final result.
Yes.
This is the final result, where you had a dissection at the distal end of the stent in the OM and also a dissection at the distal end of the stent in the LED. But both of these were sealed with the help of two stents. And this is a stent being deployed in the distal OM and distal LED. And this is the final result. I hope now I am at the final result. So you'll see it soon that this is the final result, which shows very nicely looking both LED and circumflex without any significant stenosis, even at the LED. This is in the other view. You can see that LED right from its ostium down. So, ladies and gentlemen, we conclude by saying that it's feasible and safe to perform PCI in highly calcified left main bifurcation stenosis. IVUS guided imaging is extremely essential in all such cases to assess the precise size of the DES to be deployed in LMCA. Debulking using rotablation is helpful in optimal deployment and expansion of the stents. Two-stent strategy is required in most of these cases with significant size and distribution of the LCX. Thank you very much.
Thank you, sir. Again, as usual, showing excellent cases. Now this time with calcific plaques, and also demonstrated how the later generation stents could track through the stents if distal destruction is there. Quite again because of a better profile of this, better quality of stents. I think we have all the. Can we switch off his slides and can we have all the four speakers in the screen, please? The technical team. So we have questions, sir, which I've sent. I think we can stop sharing Dr. Gambhir sir's laptop and put all of them on the screen. Get the images of all speakers. As I keep doing it, I think one point which was highlighted is again, if you decide that the lesion of left main is complex, and then probably two stents are required to treat, and better follow it and do a good job, because unless the results immediately are good, then long-term results won't be good. But we need to become wiser to decide which is a complex and which is simple type of lesion. And throughout our experience, we keep tending to acquire the skills to decide which is a complex and which is a simple lesion. And it's very important to decide the plan properly, and we should be also go according to the plan. But in case if you have any urgency or some problems, change. And again, you should have a good team to change and manage these situations. I think with this, I will take questions from the chat, sir. Is Dr. Ferenc is still there?
Yes, I'm here.
Yeah,
Yes, I can hear you.
yeah. We still see. We can we have all of the all four in the screen for discussion sake? In the technical, we can see Fazila. We are getting each of them. I'll get you presenters. I think this one can change the screen.
Uh, so if they make it to the full screen,
Yeah.
you'll see everybody on the page.
Yes, I think we are able to see the full screen. Thank you all for your time and for the excellent lectures and showing very good cases. I think hope all the listeners in our webinar enjoyed it. And because we have presence of Dr. Ferenc here, who has dealt with some of these COVID experiences too in this, some questions came obviously regarding that. And again, it was seen before. Don't change it. Smith is coming. Anyway, I think all of the speakers can listen, hear me, no?
Yes.
Yeah, I can hear you.
Yes,
Yes, yes.
we can hear
All
you.
speakers can hear you.
Yeah. I think the questions is, as there is a drop on patient inflow, patients are staying at home in bearing chest pain. How is the current practice in Germany for patient connect? What did you do any changes in follow-up or the treatment connect to patients in COVID era in the form of telemedicine or teleconsult, something like that? This is a question being asked to Dr. Ferenc from Dr. Sharma. Did you get the question, Dr. Ferenc? Yes.
Okay, so what we have done, we, at least in our region, we make it very clear for doctors community, we should be one of departments COVID-free. This was the first idea, to try to isolate our center from COVID patients. And the first very bad experience we had was to get patients from different centers, and with information that COVID test was negative. And exactly 2 days later, few of such patients develop fever symptoms, and they were, of course, positive. And this is the huge problem. So we, in our center, we have 300 cardiovascular beds. What we have done 2 departments only for COVID dedicated patients, right? So with protection for doctors, nurses, and they were informed, personnel, doctors, nurses, they were informed. Everybody could be potentially COVID patients, and that's why you have to take care. And what was the most important point, that the social distancing was working in Germany very well. So if this was the most important point. Other point was to take masks. So in hospital, we now working from the morning till the night, everywhere with mask. So this is, I think, very important topic. If you go in Germany to the shop, you have to wear a mask. We informed our doctors, on the family doctors, they can send us patients, and we try to treat patients. But still, there is a problem. Even if we call the patients and say, please come, we have now time and capacity to treat your CTO or whatever. And some percent of patients, around 10%, they are still very skeptic, and they try to avoid contact with hospitals. So there's still a lot to do, but I think you should contact, in majority of cases, family doctors or smaller connecting institutions to tell them you are able to manage acute coronary syndromes, you are even manage to unstable patients. They should come. They shouldn't stay home to wait too long, because they either die or
And it's our duty also now to educate the patient that we are treating them safe, and both ID and these departments are separate, and there's no worry of cross infection. I think India, fortunately, we don't see that many cases who are becoming very sick, sir. And as you said, there is some data collection from India that ACS and MI patients have gone down in these COVID times in April compared to what we had in the last years. I think similar experience you also faced, but you felt it mostly because they're staying at home. And that is about COVID, and a lot of interesting questions. I hope you have about 10-15 minutes time.
Yes.
Yeah, a lot of interesting questions which came across the technique of the left main. I request the speakers to give your valuable opinions on these important aspects of the coming questions which are being sent. Number one, if the left main ostium is not involved and the disease is there only in the mid to bifurcation, there are some schools of thoughts which said that the entire left main needs to be covered. Others feel it is only from the mid part to be covered. What are your thoughts on it, and how do you decide on it? I think you can respond, and later Gambhir and others will can take it.
Yeah, the very clear message to everybody: if you have distal left main bifurcation and your proximal part of the left main is healthy, and your left main is long enough, then you could just go from the lesion. Maybe you go from healthy part of the distal left main, perform distal left main management. That's okay. You don't have to stand complete the whole left main. If you have short left main with a distal left main stenosis, then I would definitely recommend not to leave 2-3 millimeters area without stenting. Then you just go from the ostium to the LAD or circle with the first stent, whatever. And do not forget to perform optimal post-dilatation with non-compliant balloons. This is, I think, very, very important. And we saw great cases. If you have really calcified lesions, always consider the bulking technique, which is in many cases, as we saw from previous speakers, excellent cases with rotablation as a plaque modification. So short left main, overstent, a very long left main, just go to the lesion.
Okay. I think all of the other speakers, Professor Gambhir, I think you will also agree with the same strategy because most of us follow the same.
Srinivas, yes, I do agree with our friend from Germany. The only point I would like to highlight here is, of course, I would certainly not like to send the ostium if it is free of disease. I would send it only from the a millimeter proximal to the point from where the lesion is starting. That means if it's in the mid LED, I start only from the mid LED. I just putting the stent 1 or 2 millimeter proximal to the start of the lesion, not the ostium. Now, there's another reason behind it. See, if you put a stent from the ostium of the left main coronary artery, at least in my experience, in 3 of our patients where we had to stent the left main ostium due to some reason or the other, while we were negotiating balloons and wires downstream into the vessels, of course, guiding catheter in and out is not uncommon. And we, in 3 cases, sandwiched the proximal part of the stent with the guiding catheter. The stent crumbled, and the various struts of the stent they started crumbling with each other, and we had to then we of course fortunately realized it on time, and then we had to put another stent over a stent to exclude this crumbled up stent struts of the previous stent and thereby get a good result. But then we were always apprehensive that we have put too much of metal also in the left main. Of course, left main can take up, but then this is always apprehension. So I think I fully agree that don't send the left main ostium unless it is really required.
Yeah, I think in general also osteal disease tends to have a little more higher chance of restenosis unless it is required. We should be working too much on the ostium unless you don't have a space to lot of echoing. Unless you don't have a space to avoid it, that's what is the message and the consensus. And the next question, I think Dr. Professor Fazila and Rajesh also would agree with the same. We'll go on to for the benefit of taking more questions.
Here I want to add about in case one has to see whether we do have enough space in the left main for final kissing.
Pot.
In case we don't have, then we have to extend the stand up to the ostium of the left main. Second thing is repeat intervention. One should be careful how much stent is protruding in the aorta, and then it can create a problem. So these are the 2 things which has to be kept in mind when you are extending the stent to the left main ostium.
Yes, Dr. Gambhir also was mentioning about distortion of the stent if you don't take care, if the stent is protruding into the ostium. Dr. Fazila, do you want to add anything?
Well, actually, yes, absolutely what everyone has said. I totally agree with that. As I showed, they had significant disease in the ostia. That's why we covered the
No,
ostia.
that's fine. In
Yes,
general,
yes.
as a strategy,
In
if you have
general,
disease in the ostium,
absolutely,
you can't help
yes.
it.
Absolutely. If you have disease, obviously you have to do that. But
Yeah.
if ostia is disease free, of
Yeah.
course you avoid that. And as Dr. Gambhir has brilliantly pointed out, because you're going with a lot of hardware. If you put a stent in the ostia, it obviously restricts your movement, and there's every chance that you might distort the struts while going about doing kissing or and taking balloons down. So, and one thing is that IVUS helps you. If you see in a IVUS also imaging your ostia and its surrounding area is free, you know that you're going to get a result anyway. So, of course, what everyone has said, I totally agree.
Dr. Mohsin, from your place, I think wants to know, madam, you are using Resolute Onyx stent for majority of the cases of complex distal left main intervention. Can you please
Yes.
highlight the advantages of this stent?
Well, actually, yes, we do use a lot of Resolute on it, and we talked about it in the summary. Nowadays, lots of stents actually do have these qualities with Resolute design, right? Because it is designed has allows you great side branch accessibility, and that I feel is one of the greatest benefits that you get when you use a resolute onyx in a bifurcation situation like a left main. And it's got 5 millimeter size. When it's a large left main, and in 75% of cases, we know a left large or larger than 4 millimeters, and resolute onyx comes in 5 millimeter size. So a proper sizing of a large size left main can be only proper with a resolute onyx, and it's got great radial stent which helps in the left main situation. So, and it's got great deliverability, especially in case of LCX, which is very tortuous, which is calcified, or which is a 90 degrees angle. In those cases, resolute onyx just slides through that. So you, for great deliverability, great radial strength, great side branch accessibility, well as other features like great radio opacity, resolute onyx is one of my favorites, yes.
Other advantage also, I think, is differential expansion. Suppose you're doing a crossover stent where the
Absolutely,
left
yes.
side is bigger, you're doing with the bigger sized balloon pot, probably because of structural differences in the stent. Stents doesn't get distorted. It expands well in the left main and will remain all right in the LED. That is another important feature for the
Very important feature. Thank you for reminding me of that. Yes.
Yeah.
Like if you've got a mismatch in size between your left main and your proximal LED, it works very well. That so you take a larger size balloon for the left main.
Earlier version of the stents used to get distorted, and the distally they used to become narrow when you expand more proximally because of connection patterns being different. This is another advantage, I think, with the later generation type of stents. Other questions which came a lot on imaging modalities. I think Professor Rajesh has fascination of OCT imaging, and each of us could have some preferences with IVUS or OCT. Basically, which should be whichever we are comfortable with, probably you can use it. And availability is also an issue. If you have both, then the question comes: which do you prefer for what? One most important question I would say is asked regarding diameter assessment of stents. Are you using minimal luminal area, media to media, or intima to intima? I think this varies with imaging. I think Professor Rajesh would like to take that.
So it's a extra elastic membrane for the OCT to have now minimal luminal area and vessel diameter. So it's an extra elastic membrane, and same extent for media for the IVUS. Regarding the use of IVUS versus OCT in the left main, imaging with the dye is an important concern for the OCT, while without the dye, you can very well do the IVUS. Those patients who have a low ejection fraction and somewhat critical can go ahead for the IVUS instead of the OCT.
Yeah, I think in osteal lesion again, I was scored slightly because the
That's right.
inside.
Osteal lesion, it's always the IVUS and not the OCT.
Though sometimes we'll be able to try to position it just proximal to the osteum, give injection, still you won't get very ideal pictures.
But after doing the stenting to assess the ostium of the left main, you need to have IVUS. So it's better to have IVUS pre PCI and also post PCI instead of say OCT pre PCI, and then to assess the ostium of the left main whether it's well covered with the stent by doing the IVUS.
Yeah, Dilmange more, we want always the best to the patient. So pre-imaging with IVUS and post-imaging with OCT to see
No, so
that position and malposition better. That's all is fine.
so
But whichever the operator is comfortable, I think we should be
that's right.
most important.
And for the ostium, I would say that it's better to go ahead with the IVUS instead of
Yes,
OCT.
yes. And the final point, I think we're coming to time is ending, sir. I think we need response from all the speakers here. As we all agreed, and even Ferenc pointed out that LCX ostium is a difficult animal for us to conquer yet. Though we are doing good results, great results immediately, but many times you do get patients back with LCX osteal restenosis. I think we'll start with Professor Ferenc. And what is your approach? A patient coming back with LCX osteal restenosis after we did a bifurcation stenosis.
Yeah. Can you hear me?
Yes,
Can
yes,
you
we can
hear?
hear you.
Yeah, I think this is really unresolved problem for the distal left main. So we have excellent results for left main to LAD stand, but in the circ there is still unresolved problem. What we do, what I have learned, I take care more and more to perform the bulking for osteal circ. If we have calcified lesions, and we usually go with IVUS, then you see there is a need for rotablation. And it was wonderful case from Dhaka, from Dr. Fazila, showed how important it is to use stepwise debulking. So you use it 1.25 just to be sure. Then you went to bigger burr just to try to ablate a bit more from the calcium. And this is the similar approach in our center. So we are now more aggressive to perform optimal debulking for osteal circ, and then to use usually a stent with optimal radial forces, which is onyx. This is our also favorite in left main and calcified lesions. And but still, if we have restenosis, we have to treat patients with drug-eluting balloons. We try to avoid stent in a circ. We use here more drug-eluting balloon technology. So this is my answer to this question.
Professor Gambhir, do you have any concerns of doing rotablation in instant restenosis when stent is already there at LCX ostium?
Not really. In fact, I'm a great proponent of doing rotablation for instant resources at all sites, both at the LED ostium and the circumflex ostium, and particularly circumflex ostium. In fact, I have several cases by now, big vessels, because I'm talking of a series where a patient has undergone the left main bifurcation stenting, and when they have come back to us with angina, by and large, 90% of them had a stenosis predominantly or only at the circumflex ostium. So in those cases, we do a good debulking. And a slight difference of opinion here, I am not very keen to use a 1.25 milliliter per straight away in these patients. If the vessel is more than 3, I straight away go with the 1.5 milliliter per, because 1.25 has a higher tendency to get stuck than the 1.5, because when you are pulling it back, then it gets stuck up in the region. Because when you are pulling it back, it doesn't cut. So I go with 1.5 milliliter per and optimally deploy, debulk, because the maximum bar that we have got is 2 millimeter. So generally we go up to 1.75 and occasionally up to even 2, and then put a stent in stent, as I told yesterday also, putting the new stent a little bit about a millimeter or so into the main. So whether it really works or not, I don't know, but patients do come back with a re-stenosis. So it's a real challenge, in fact. So debulking, of course, should be done in all these cases.
I think there is some data just coming up with imaging saying that with the residual plaque volume is more than 50% after you work up everything, then probably just doing drug-eluting balloon may not be totally effective, and it could again come back with restenosis. In such case, I think you should take the help of second stent DS of different make. But if you have done enough of debulking with all the material decreasing to less than 50% of the plaque volume, what was there before pre-starting the procedure, I think a drug-eluting balloon could still do the job. I think we are definitely wanting to have more solutions more for this problem.
Dr. Sreenivas,
Yes,
I would like to add over here that
yes.
osteal abscess instant restenosis is commonly associated with under expanded undersized stent, and therefore any patient who is subjected for the bifurcation stenting, it's better to do have the imaging and have the optimal osteal FCX result.
That point is well taken, because we are all talking once the stent procedure is done well, still the patient comes with restenosis. I think the various options are still under discussion. And the last point, which I would like to clarify for the webinar to our viewers, is in India and same in Bangladesh too, I think we do see a lot of ACS young patients with left main problem. You have shown actually, in fact, one of that case, though you said inferior MI did RCA first, but left main also had a very critical osteal disease, bifurcation disease. And some people would argue that that left main could be tackled first because RCA was not critical. But what are your thoughts if a patient of left main in a ACS situation, once you did a procedure and patient gets into slow flow or no flow phenomena with low pressures, then that is still an area again. We are interventional cardiologists in acute syndrome, coronary syndrome, MI level, we get into trouble. So, what are your various bailout strategies when you are dealing with such situations? It would be,
So basically, whenever this type of situation, it's the team approach, and then you have to be very fast to tackle any complication. In this particular case, I did the RCA first, just to have a backup with what's our plug button is there, the left main and also the LAD. There was a risk to have a slow. And we did give the tirofiban infusion since when I did take patient for the left main infusion. Uh, First angiogram before going ahead for the PCI of the left did show a slow across the LCX, again suggesting that it's acute coronary syndrome and then a thrombotic load, and therefore tirofiban was. Um, Regarding the no flow or slow flow, people do use nitroglycerin, nitroprusside, but I have seen in such situation when there is rapid deterioration of the patient, it's better to give coronary adrenaline. And I have seen my patient a great response, and it do help in rescuing the patient. So that is an alternative not routinely been used for say slow flow or no flow phenomena, but this has a very impressive result.
so Professor Ferenc, what is your drug of choice if you with slow flow, no flow when you're getting it?
Yeah, of course, if we have a very critical distal left main and really reduce LV function, as I show in my first slide, then we try to put perform impeller protection PCI, but not everybody has impeller. Not everybody has experience. It's not so easy device than some people believe. You need some experience to use it this adequately. But what we do, we usually work very fast. I think to work very fast is one of the important points. And I also try to give noradrenaline to have some push in pressure. If the pressure is coming and the stenosis is treated, then the patients can recover much faster.
Yeah. Somebody wants to know what is the percentage of radial procedures in your center before we go on to gesticle.
Yeah, in our center we do around 80% radial, primary diagnostic 80%. We do a lot of complex PCI, so we need 7-8 French. Then we go, or CTO, we go usually with to shit. I have to go now to TAVI, to TAVR procedure, so I have just 2 minutes. What I like to, D.S.Sreenivas, thank you so much for the invitation. Thank you to Medtronic India for organization. I think it is really good option to stay in contact and to keep in touch and to educate young doctors. So many greetings to India and to Dhaka. Thank you so much.
Thank you.
Thank you, Dr. Ferenc.
Thank you, and see you soon.
Thank you.
Yeah. Last words from Professor Gambhir, sir. You were about. Thank you, sir. If you have to leave, probably we can continue.
No, I just wanted to make 2 or 3 points about the slow flow because there are a lot of young interventional cardiologists in the audience. See, there are 2, 3 things which are often forgotten and can be tried, should be tried, and do help. One is auto-perfusion, particularly in the right coronary artery. Many of the people are really not aware of this terminology. What we do is that when we do angioplasty, primary of the, let's say, right coronary artery, what we do is that if we have to do a 6 French guiding catheter, then we put a 7 French sheath. We do it from the femoral artery. And if we have to put a 7 French guiding, we put an 8 French sheath. Now, if a slow flow occurs, then we take out the blood from the side arm of the femoral artery sheath and push the guiding a little bit into the ostium or a little well into the ostium of the right coronary artery and forcefully inject this blood which has been withdrawn from the femoral artery side sheath forcefully through the guiding catheter. This helps in pushing down the debris and invariably, I won't say invariably, but at least 80% of cases, slow flow tends to decrease once you've done it 6-7 times. Now, along with that, we also give mephenteramine or noradrenaline to raise the blood pressure. So, two things. One is raising the blood pressure. Secondly, pushing this debris or which are responsible for slow flow and choking the microcirculation. And thirdly, in LAD or in circumference, particularly in LAD, what we do is we put a micro catheter down below into the LAD and push one of these agents that you have enumerated. Put nitroglycerin, but we can put nicorandil also, we can put also, and they go very well into the channels, and that leads to the slow flow. The only word of caution in nicorandil is known to give rise to VT on the left side, known to give rise to EV blocks on the right side. So be careful. Nitroglycerin is safe. I have no experience of using adrenaline because I don't know whether it is arrhythmogenic given through a microcatheter or not. So a few things which are in addition to what everybody, this helps because we do a lot of rota. We are almost doing 15, 17 rota. Do come across once in a while, you treat it like this. And then if nothing else, then of course IABP has.
Thank you, sir.